Kawasaki disease in 5 minutes. You have a 6-year-old girl with persistent fever for 5 days, erythema and cracking of lips, strawberry tongue, erythema of the oral and pharyngeal mucosa. Her eyes are red without eye discharge, non-pruritic maculopapular rash all over the body. She has unilateral cervical lymphadenopathy 2 cm in diameter. What is the most likely cause of her persistent fever? Acute rheumatic fever, Kawasaki disease, erythema infectiosum, or scarlet fever? The correct answer is Kawasaki disease. Kawasaki disease is acute vasculitis of childhood. This can lead to coronary aneurysm in 25% of untreated cases, so early treatment is critical. The hallmark for diagnosis of Kawasaki disease is persistent fever 5 days or longer. Persistent fever 5 days or longer. So again, fever for 5 days or longer. This is the most important one to start with. And 4 of the following. The lips will look red and dry, erythema and cracking of lips. Tongue will look deeply red with white spots, well known as strawberry tongue. And or erythema of oral and pharyngeal mucosa. Next one, the eye will be red without eye discharge, deeply red without eye discharge, is well known as conjunctival injection without exudate. And body rash. Rash can be maculopapular or diffuse erythema or erythema multiforme. The rash will be circles and wavy-like. Next one is erythema and edema of hands. The hands will look red and swollen, or desquamation. The desquamation will look sheet-like. And cervical lymphadenopathy is the last criteria. More than or equal 1.5 centimeter. So in the cervical area, you will feel a large lymph node, and usually on one side. Challenging cases of Kawasaki disease, well known as incomplete Kawasaki, like children with fevers 5 days or longer, and just 2 or 3 compatible clinical criteria as we mentioned in the previous slide. Or younger than that, the infants with fever 7 days or longer without any other explanations. Supportive laboratory studies, very important to have in these cases. For example, SID rate more than or equal 40 and CRP more than or equal 3. Platelets more than or equal 450 after day 7. In most of the cases, platelet will be elevated on day 7 or longer. And white count will be elevated as well. Other supportive labs: anemia, very common in Kawasaki, low albumin, urine more than or equal 10 white blood cells, is well known as sterile biuria, elevated transaminases, AST, ALT, or GGT, or elevated bilirubin, hyperbilirubinemia. This can occur in 10% in cases of Kawasaki. Echocardiographic findings in case of Kawasaki: coronary artery abnormalities, the most common aneurysm, valvular abnormalities, mitral or aortic valves, aortic root dilatation, myocardial dysfunction, or myocarditis. It is very important to start the treatment immediately once the diagnosis of Kawasaki disease is clear, without waiting for the echocardiography to be scheduled or waiting for the result. Once the diagnosis of Kawasaki disease is confirmed, treatment with high-dose IVIG is required, which is 2 grams per kilo, should be given immediately and continue until the patient is afebrile for 48 hours. For the treatment to be successful, should be administered within the first 10 days of illness, or as soon as possible after the diagnosis. How to control the fever? By giving high-dose aspirin, 80 to 100 milligrams per kilo per day, until the patient is afebrile. Then low-dose aspirin should be started once the child has been afebrile for 48 to 72 hours. For how long the low-dose aspirin should be given? 6 to 8 weeks after the onset of the illness. Then you can stop it if the echo is normal. How to deal with incomplete Kawasaki? If CRP is low and ESR is low, continue to monitor the symptoms. If the fever persists, order an echo if skin peeling. If CRP more than 3 and ESR more than 4, treat if positive echo, or start the treatment if more laboratory findings, for example, anemia, thrombocytosis after day 7, low albumin, elevated ALT, white blood cells are elevated, urine more than 10 white blood cells.
Having trouble or trying to pass the pediatric board exam? We have the definitive solution for you, presenting the Last Minute Review Series, a powerful tool for achieving success in pediatric board exams, crafted by Dr. Osamu Naga, a board-certified pediatrician by American Board of Pediatrics and the editor of the Pediatric Board Study Guide, a last-minute review. Dr. Naga breaks down the most critical subjects in this series. The Pediatric Last Minute Review webpage offers a thorough and rigorous set of pediatric board review sessions that are in line with the study guide. The lectures will cover the most important topics for each condition that a pediatrician must know for pediatric board exams, as well as real-life clinical encounters. The inclusion of a clinical case scenario, accompanied by multiple-choice questions, followed by the most probable answer and a comprehensive description of the issue, will ensure test readiness for each student. You will be able to download the lecture's PDF files to make your studies easier, to take notes and be accessible on the go and offline. Based on the membership plan you choose, you will have unlimited access to the lectures for either 1 month, 3 months, 6 months, or 1 year. By viewing these videos, you will increase your chances of passing the board exam and gain substantial advantages from the acquired knowledge. Additionally, by studying the material and completing the AAP prep questions from the previous 3 years, you will greatly increase your likelihood of passing the board and will acquire a wealth of knowledge. Click on the link provided below to visit lastminutepediatric.com and subscribe immediately. Be sure to take advantage of our free video samples on our YouTube channel, Pediatric Board Last Minute Review. Good luck with your exams.